discussion at the end, and let's enjoy the very interesting talk given by Dr. Abdulrahman Alturki. He's a well-known consultant vascular and interventional neurosurgery from King Fahad Medical City. And we are so happy to hear from him regarding the treatment of unruptured intracranial aneurysm. Thank you, Dr. Abdulrahman, and the mic is for you.
Thank you very much, Dr. Fawaz. Good evening, everybody. I would like to thank, first of all, the organizing committee for having me. And it's always difficult to present after my dear friend, Dr. Hussam. He elegantly presented the clinical and radiological aspects. Let me put up my presentation here. Moving on, I don't have any disclosures, and it really now comes down to the patient in your clinic. Really, after we had the nice discussion about the clinical and radiological and dynamic features of the aneurysms, now I have this gentleman in my clinic. It really comes down to two questions: who to treat and how to treat. The optimal treatment for any unruptured aneurysms depends on the patient factors, the aneurysm factors, and the surgeon's factor or the interventionist factor. So it depends on the age, the condition of the patient, the aneurysm features and characteristics that were elegantly described by Dr. Hussam Al-Jihani, and the ability of the surgeon and the availability of endovascular treatment options. All these things that I spoke about must be weighed against the natural history of the condition. If you cannot beat the natural history of the condition, do not treat this patient. And I will explain that as we go. So again, I'm just bringing these scales that described by Dr. Hussam. We have the phases and the elapsed score. These scores helps us to gauge the risk for the patient. You have to individualize every patient. This is not all one size fits all. So I use those scales, but I have to also put the patient condition, patient psychology, patient risk factors, and the other things that are not mentioned in those scales. It is not really treatment methods. It is management options, I would say. And there are three management options. We're talking about observation, surgery, and endovascular. When we say observation, it does not mean that, okay, you have a 3 millimeter aneurysm, probably not to touch it is the best option. Just go ahead, I will follow you on annual basis. No, this is not the way to do it. I will elaborate more on that. We have a dilemma, as alluded to by my colleagues. With ruptured aneurysms, there is a controversy on what's the best management options to use. This controversy is even harder and even with additional uncertainty on which aneurysm to treat if it's unruptured. So we're only not discussing or arguing about the best method here, or we're adding to it which one to treat. So the question is a little bit more difficult in an unruptured case. And unfortunately, we don't have randomized controlled trials comparing intervention versus conservative management, or even comparing different treatment options that we have in hand. The data we have in hand are mainly personal series or large retrospective studies. They are plagued and have lacked objective short and long assessment of outcomes. Just to tell you that someone actually studied the disagreement between treating physician, Dr. Tim Darso in Canada grouped up his colleagues and actually showed them a similar lesion or similar aneurysm. So he found that practitioners do not agree regarding management of unruptured intracranial aneurysm, even if they had the same background of specialty training, similar capabilities of aneurysm management, or even years of practice. So this will tell you a lot that this is a hot topic that we always have different point of views when we approach it. So currently, our best information regarding management of unruptured intracranial aneurysms is an observed rates of complication in aneurysm treatment compared really to the natural history of the disease. So that's what we have in hand right now. Let me just move the screen a little bit away. All right. When we choose to observe a patient, it means that we have to, first of all, counsel the patient for the rupture risk that Dr. Hussam mentioned, and be honest with him that that's what really have in the literature. And it is imperative for all patients that they are treated conservatively, that they should be counseled about their potential risk factors, smoking, hypertension, and their effect on the aneurysm risk of rupture and aneurysm growth in the future. And then choose the appropriate imaging modality regarding duration and follow-up. I'm just going to mention one medication, which is aspirin, which has been the hot topic right now over the last 3-4 years, to use it or not to use it with unruptured intracranial aneurysm patients. There are many retrospective studies have suggested that rupture risk is actually reduced in patients taking aspirin. However, it remains unclear where the benefits of aspirin use in patients outweigh the potential risks. What if they rupture and while they're on antiplatelets? Does that make their rupture worse or not? Actually, someone studied that. And in an excellent study of more than 700 patients consecutively followed up, the rate of hemorrhage was higher among patients who did not, and I emphasize here, did not take aspirin compared to patients who took aspirin. But the overall morbidity and mortality did not make a difference. So this will tell us a little bit about the safety of taking aspirin, even if the aneurysm ruptured in the future. In a case control study of 1,000 and almost 800 patients, cases of intracerebral hemorrhage and subarachnoid hemorrhage, when they looked at the aspirin use, it was actually associated with a decreased risk of subarachnoid hemorrhage compared to non-aspirin use. So there is a building body of evidence supporting the use of aspirin in patients with unruptured intracranial aneurysm. When they analyzed the data of the ISHUA study, which is the longest, biggest study that we have so far, when they looked in the untreated cohorts and they selected the patients who took aspirin, they found actually they had a lower risk of aneurysm rupture during follow-up. So this also supports the use of aspirin. In my practice, I started actually recommending using aspirin, especially for elderly patients above 40, where there may be another risk factor like cardiac or something else to push the indication a little bit. So to answer you with regarding to observation, focus on the modifiable risk factors, may consider aspirin use in those patients. Moving to the surgical clipping. Dr. Hussam elaborated on the morbidity and mortality. I will elaborate more here. In a finding in a meta-analysis of 733 patients underwent clipping in an unruptured aneurysms. All of this literature is in unruptured intracranial aneurysms. They found a mortality of 1% and a major morbidity in 4%. In a larger meta-analysis of more than 2,400 patients, they found the mortality and morbidity to be 2.5% and 10%. The ISHUA trial, which is the international study of unruptured intracranial aneurysm, found a surgical mortality of around 3.8% at 1 year, and morbidity and mortality of 12% around 1 year. In comparison to the combined morbidity and mortality for the 450 patients who were treated in the endovascular arm of the ISHUA trial, it was found to be around 9.5% at 1 year. It was found that the morbidity and mortality was greatest in the surgical arm in those aneurysms that were large, which makes sense, it will be more difficult to treat, and in the posterior circulation, and in the elderly patients. And I put it between brackets, some studies found that there is presence of calcification, which will make the clipping more difficult. Just for the audience who are not familiar with surgical approaches, this is a view of a terional approach where you see the optic nerve here, and this is the internal carotid, this is the middle cerebral artery, and this is the anterior cerebral artery. This is a PCOM aneurysm that was clipped, and this is an ACOM aneurysm that was clipped. You can see the ipsilateral optic nerve, contralateral optic nerve. while there will be always a role for clipping, endovascular therapy has emerged as a first-line therapy for most of us, interventional neurosurgeons, and even our colleagues in radiology and in neurology for most aneurysms. But the discussion is still hot about particular aneurysms in particular locations, namely in the MCA, middle cerebral artery, and most of the posterior inferior cerebellar artery aneurysms. Now, it's always a moving target, the discussion between clip versus coil or coil and other technology, given the fact that as long-term data about endovascular treatment are becoming available, it will support this particular modality at that time. But the problem is the technology is always evolving. Coils, we have multiple generation coils, different company, different configurations. Same goes with the stents, same goes with other things. So the data of that particular device will be rendered obsolete. You cannot generalize the findings of, for example, per-platinum coil versus hydrogen or hydrogel coil. You cannot use those data to argue in favor of coiling or against surgery. So that's the dilemma or the problem we are facing with as more data we have on different devices. And just to pinpoint the importance of age, in one study, it showed that the procedural and in-hospital morbidity and mortality increases with age in patients treated with surgery, but remain relatively constant with endovascular treatment. So that's why usually we shift toward endovascular treatment in elderly patients. Now, let's talk more about clipping versus coiling. In a meta-analysis, one meta-analysis just grouped up all studies, like bananas, oranges, apples, everything, and it showed that clipping results in significantly higher disability compared to coiling. However, when you look into the subgroup analysis, it really did not make any difference on the long-term outcome. And it actually showed that mortality in hospital and overall hemorrhage, infarction, there was no difference between the two groups. And we have always to take meta-analyses with a grain of salt. Actually, not with a grain of salt, with a bucket of salt, especially when you group up retrospective, personal series, institutional expertise, group them up together, try to squish the data to reach a conclusion like this. So we have to be very vigilant about conclusions like these. The list of endovascular tools is getting longer and longer. Every year we have a new generation of the similar device. Every couple of years we have actually a newer device that helps in an endovascular management. This is just a battery of things that we use here. You have simple coiling, or let me just get out from the, you have simple coiling, you have a balloon-assisted coiling of the aneurysm, single stent-assisted coiling of the aneurysm, double stent or Y-stent coiling. We have the waffle cone configuration. We have, which we don't use here when you use glue. We have flow diverters. We have the pulse rider, and the list goes on and on of devices that we can use in the endovascular arm. This is a more colorful picture of what I have mentioned. And just imagine there is literature for every single device of these. And when you have a new generation in that device, the literature will change. So you have to, when you counsel a patient, you have to have the knowledge of these studies and actually the morbidity and mortality of each one to compare it to surgery, to compare it to when you choose the observational arm. I'm going to speak in the next couple of slides about flow diverters, because it's picking up really as an endovascular tool when compared to the other modalities that we're using. So flow diversion is actually we use stents. When we compare it to the other stents, it's really, the difference is in the surface coverage. You can see it's more, the surface coverage in a flow diverter is higher than the regular stent that we use in stent coil. We're talking about a surface coverage of between 8 and 15% in this stent. And in flow diversion, we're talking about 30 to 35% surface coverage. Why is that important? Because it is designed to, I'm going to choose one company here, which I shouldn't, but flow diversion in general, the stents, are used to reconstruct the barium vessel by diverting flow from the aneurysm. How does it do that? Well, this is an autopsy that I performed on a patient in my fellowship 3 weeks after putting a stent. She died from an accident. And you can see these are the struts of the stent. And this is the aneurysm and a thrombus forming here. It is not the thrombus that's going to obliterate the aneurysm. It's the endothelialization. You can see endothelial cells are climbing over the stent. And the stent is forming like a scaffold for growth of the endothelium over it. So with time, and usually we give it around 3 months, the artery will regenerate around the stent and will perform a full and new endothelial layer. Hence, it will shut off the flow inside the aneurysm with time. Now, we speak about on-label and off-label use of those devices. The FDA in the United States only approved flow diverters to be used in basically large and giant aneurysms in the anterior circulation. The indication for this, the on-label use is getting smaller and smaller and smaller and smaller. The off-label use is basically just skyrocketing. On every vessel, we can use it right now. It is usually a mixture. The flow diverter itself is a mixture of cobalt, chromium, and platinum tungsten. And as I said, the surface coverage is 30 to 35%. Just to give you an idea how good is this device if you choose it wisely for an unruptured aneurysm. This is the BUFS trial, which is the first trial that gave the FDA the power to approve this device in the United States. They treated more than 100 patients with a wide neck, large, giant aneurysms in the specific segments in the internal carotid artery. Occlusion rate is 95% at 5 years follow-up. Once the aneurysm is closed, the chances of recurrence is 0, which is phenomenal. We didn't have this before in other devices. The morbidity and mortality at 6 months is around 5 to 6%, which is acceptable. They call treatment success if the aneurysm is 100% occluded. So this is great. This is phenomenal. This is a game changer for us in the interventional field. As Dr. Hussam presented this diagram, now I spoke about observation, surgery, endovascular, and it's all options that we have. Too many options to choose actually from. Now the difficult task for you as a clinician to choose which of these different modalities is best suited for your patient. And to make it more complicated, I have even a better diagram compared to the previous one. I'm going to simplify it. In the decision analysis, I like this study because it's actually looked into the risk factors. It's published in the Lancet in 2014. One of the proposed strategies in managing these aneurysms, if it's a large or symptomatic aneurysm causing pressure symptoms, it should be treated, especially in young patients. If the patient is less than 60 years old with a small aneurysm in the anterior circulation with no risk factors, you can actually medically manage the patient or observe him. Once you have an aneurysm in the posterior circulation or symptomatic or with a strong family history, and intervention should be entertained. And if you plug these risk factors in the scores that we spoke about, the score will become high. So the risk of rupture will be higher. In elderly patients, however, you have to be very careful because you have to justify the risk for the intervention. Usually in smaller aneurysms, less than 7 millimeters, with no risk factors, observe them. If you have a risk factor, you can propose intervention. The bigger the aneurysm, with the focus on the posterior circulation, you should push toward intervention. Now, how to choose among different modalities? I don't think this is the venue to discuss it, but usually we look into the characteristics of the aneurysm once we decide on is it surgery or endovascular. after we discuss the patient risk factors, and then based on the geometry and the vasculature of the aneurysm and the circulation around it, we choose one of those modalities that I spoke about and I showed you in the pictures there. So, some general thoughts at present after practicing in North America and here. Younger patients with aneurysms larger than, here, if you notice, I changed it from 7 to 4 to 6 millimeters, they are generally considered for treatment, especially in the United States. In the United States, if you have an aneurysm larger than 3 millimeters, you will get treated. Somebody will push you to get treated. Of course, the younger the patient, the stronger consideration for treatment. And I cannot emphasize on this point, as Dr. Hussam presented here, and Dr. Fawaz and my other colleagues. Input from several physicians working together, neurology and radiology and vascular neurosurgery, is extremely helpful. It will open different perspective for you, even if you know how to treat those aneurysms. But counseling the patient and what to tell the patient and how to approach the aneurysm, choosing one modality versus the other, it is extremely helpful to have input from others. So, for example, we have a weekly conference here at King Fahd Medical City where we discuss, especially the unruptured cases, because every colleague have his input on how to fix this, and then we reach a conclusion and we share this final conclusion with the patient. I find it extremely helpful, and I cannot overemphasize on this point. At present, patients are evaluated on case-to-case basis, trying to incorporate the true morbidity of the treatment, as we mentioned before, balanced against the best estimate of the natural history for that individual. So you cannot basically stamp every aneurysm with the same cliche for treatment every time, even if it's the same size, same location. You have to look into other factors, and patient factor, your factors as a surgeon or as an interventionist, and the aneurysm factor. And this is the last point, and we are always unfortunately overlooking it or not considering it, which is the psychological and the social factors, which are extremely important here in the final decision. You have to look at your patient and see, try to treat his anxiety with treating his aneurysm. It is a big shock to be diagnosed with an aneurysm. And once people start reading in the literature, it's always scary. So your job as a professional is to reassure them, treatment is there. We are hopefully going to choose the best treatment for you based on the things that I discussed. And this is my last slide. Thank you very much.
Dr. Abdulrahman, it's very nice talk, really. And just to re-emphasize in taking decisions in life in general and in unruptured intracranial aneurysm precisely. And to tell you the truth, we reached to the point that we're making clinic together. So last time I was in the clinic, sharing clinic with neurosurgeon and neurologist and neurointerventionist in the same clinic, facing a patient with unruptured aneurysm, and we didn't reach to the conclusion. And we were pushed by the patient while we're doing the only cerebral angiogram to treat it at the same time. We are telling them decision is not easy. We are facing you in the clinic, and we are doing a weekly meeting to decide what is the best advice for you. And actually, between neurointervention or clipping or another disease like embolization and AVM, we're trying actually to help the patient. And sometimes even with all these diagram and pathways that we have in the literature, it's not an easy. And actually, I think there is a missing, and we can now start the discussion after I thank you all my colleagues about these talks. Very interesting. It's inspiring and really educational, even for a simple guy like me. Thank you all.